The New Jersey Center for Tourette Syndrome and Associated Disorders, NJCTS, and its directors and employees assume no responsibility for the accuracy, completeness, objectivity, or usefulness of the information presented on our site. We do not endorse any recommendation or opinion made by any member or physician, nor do we advocate for any treatment. You are responsible for your own medical decisions. Now I'm going to turn over the introductions of our speaker to Martha Butterfield, the webinar coordinator of NJCTS. Marty?
Thanks, Kelly, and good evening, everyone. Before I introduce tonight's presenter, I want to mention that our next Walk for Tourette Syndrome will be in Princeton on April 2nd. If you cannot attend, I hope you'll log on to our website and make a donation in support of our education outreach programs. Additionally, I'm sure you noticed in the pre-webinar slides that there were a number of other events as well as information on our scholarship program, all of these with pending deadlines. I won't go into all the details here, but I certainly encourage you to visit our website for more information on all of those special events and when the various deadlines expire. Now to the introduction of tonight's presenter, Dr. Colleen Martinez. Dr. Martinez is a born and raised Jersey girl, receiving her undergrad, MSW, and PhD from Rutgers University. This is the third webinar that Dr. Martinez has done for us. She previously presented in August of 2015 on anxiety and test taking, and again in June of 2016 on play therapy. If you have an interest in either of those topics, you can find them in the webinar archive on our website. Dr. Martinez is a licensed clinical social worker and a registered play therapy supervisor with more than 20 years' experience providing clinical services to children and families. She has worked in a wide range of institutional environments, including medical, correctional, outpatient mental health, public schools, and in private practice with a specialty in play therapy and children. In her private practice, Dr. Martinez provides supervision and consultation to individuals and agencies, particularly regarding interventions with children. She provides school-based play therapy to preschoolers in Irvington, New Jersey, and is also a part-time lecturer at the MSW program at Rutgers University. Dr. Martinez, we are delighted to have you back, and now, without further introduction, I'll turn tonight's presentation over to you.
Thank you so much, Marty, and thank you again, Kelly, for having me here. Thank you, folks, for attending. And I wanted to talk to you a little bit about why I chose to put this webinar together for you. Primarily, it's because I find that a lot of people who are receiving psychotherapy are uninformed about DSM diagnosis. Some are surprised to learn that if insurance is paying for psychotherapy, that a diagnosis of them has been made. So I wanted to make you more informed and help you to learn about this process. So during the webinar tonight, I'm going to go over what is a DSM diagnosis. I'm going to give you a little bit of the history of the DSM, talk to you about recent changes in the DSM because the DSM-5 is relatively new to us. I'll talk to you about how DSM diagnosis is determined. I'll talk to you a lot about some limitations and concerns with DSM diagnosis. And I will most importantly talk to you about how you could facilitate an accurate DSM diagnosis for yourself or for your child. At the end, we'll have some time for questions and answers, so I do hope that I can answer all of your questions at that point. And I just wanted to note to you that I'm sharing with you my perspective as a licensed clinical social worker. I'm not from the only profession that can make a DSM diagnosis, but licensed clinical social workers are one set of professionals that can make DSM diagnosis. So let's get started. The first thing that I want you to know is that the DSM-5 is the Diagnostic and Statistical Manual of Mental Disorders, 5th edition. And it is published by the American Psychiatric Association. So that's something that's important for you to be aware of. This is a publication from the American Psychiatric Association. And why do we diagnose? Generally, people get diagnoses because they need reimbursement for services. They're seeking psychotherapy or they're seeking programming that requires some kind of reimbursement. That's the main reason why people get diagnoses or children get diagnosed. Sometimes diagnosis is necessary for eligibility for programs and services. Diagnosis is very helpful for providers to be able to communicate about clients and about treatment, so it's actually a very helpful language that the DSM provides us. And DSM diagnosis also informs our treatment. As an outpatient clinician, I use diagnosis to figure out what I'm going to do in treatment with a client, so it can actually be very helpful to me as a treating clinician. Another important question is, why is it important to diagnose accurately? And so this may seem like kind of common sense to you, but it's really important for clinicians to think about diagnosing accurately, because misdiagnosis can lead to problems, including the wrong treatments being provided. Now, if we're talking about psychotherapy, providing wrong psychotherapies isn't necessarily problematic, because what do we do in psychotherapy? We often work on relationships, we work on building skills, we work on problem solving. There aren't really problematic side effects that could come along with those kinds of psychotherapeutic interventions. But sometimes treatment actually includes medication. And so medications, you should know, all come with side effects. Some of them are more serious than others. So one of the big reasons why it's so important to diagnose accurately is because sometimes the treatment that's going to be recommended is going to be a medication. And if we have a wrong diagnosis, it's possible that that would lead to a mismedication. And we want to be cautious about that, especially when we're talking about children. So I want to give you a little bit of background so you can understand how and why people's issues started being labeled in this way, because the DSM has not been around forever. So I want to give you some background, and it goes really far back to the 1800s. And this was one of the first times that people started classifying illnesses and giving them names and labels. And really, when we were going back so far, the reason why we were giving names to illnesses is because we wanted to classify reasons for basically documenting causes of death. So in the 1800s and the early 1900s, the reason why we were giving labels or diagnosis names was just because we wanted to be able to document, why did this person die? Now, the ICD, this International Classification of Diseases, still exists today. It has been adapted many times, it has been updated many times, and the ICD is used all over the world, not only now for classifying causes of death, but also for research purposes and also for documenting clinical diagnoses and treatment, for treatment purposes. So the DSM doesn't go back that far. The DSM is something that came out of the American Psychiatric Association. And even before we got that, we got a classification, an American Psychiatric Classification of Disorders. So this is really the first time that there's an American publication, and it's in the early 1900s. American Psychiatric Association said, we want to build upon the ICD. We know that there's this international standard for giving names for diseases and disorders, but we want something that is going to outline mental illnesses, mental disorders. And so they started developing a classification system of psychiatric disorders. Now, the psychiatric disorders that were classified in these first publications were really only disorders that were for people with severe psychiatric problems, people that were inpatients in psychiatric settings. And then the DSM came around. The first Diagnostic and Statistical Manual of Mental Disorders came around in the 1950s. And so I want to kind of reflect on that for a minute. The DSM, the document that we use these days to document mental disorders, is something that's only been around for about 65 years. It's a relatively new document when we think about our history. The DSM has evolved over time and has expanded The first DSM was the first time that they tried to document disorders related to veterans being in the war. This was actually coinciding with when the International Classification of Diseases added a section on mental health disorders. So as the international document is evolving, the DSM is continuing to evolve. In the 80s is when the first time the DSM provided specific definitions of mental disorders and diagnostic criteria. Over time, this document has become shifting more from classifying reasons for death and classifying reasons for hospitalization, and we're starting to use it more to determine treatment. And as you see in the 90s, the document becomes more interdisciplinary. While the American Psychiatric Association is the public publishing group, and it is predominantly a psychiatric document, it is becoming more interdisciplinary. So we're talking about nurses, clinical social workers, clinical psychologists are becoming more involved in the evolution of the DSM. And now we have the DSM-5, which was just published in 2013. While the document is still predominantly kind of contributed to by psychiatrists, it is becoming more interdisciplinary. The other thing that is happening with the DSM over time is that it is becoming more specific in terms of diagnostic criteria. One of the things that I want you to know is that the DSM is used worldwide for research purposes, but clinicians, therapists, do not use the DSM worldwide. The DSM is used in the United States as a clinical tool, as a therapy tool. This is not something that is used all over the world. More and more, the DSM is used for determining what are the right treatments for people and their disorders, especially when treatments include medications. We look to DSM Diagnosis. I want to talk to you a little bit about changes from the DSM-4 to the DSM-5. It's been it was about 16 years between the DSM-4 and the DSM-5, so there were a lot of changes that needed to be made with this most recent publication. One of them is just in terms of verbiage and language. So we used to use the term mental retardation, and we now know that that's not a respectful term, it's not a client-centered term, so the language has now changed to intellectual disability, and that's a much more person-centered, respectful term. Another major change is that we used to have a number of different disorders that were related to autism. We had Rett's disorder, we had childhood disintegrative disorder, we had autism disorder. Now we have what we call the autism spectrum disorder, and all of these disorders are subsumed under this one category. And that's a change. And one of the reasons for this change is that we now know from research that risk factors for these disorders and treatments for these disorders are very, very similar. And so that's why they're put together under this one diagnosis name. A major change that people talk about a lot is the taking out of the bereavement exclusion for major depressive disorder. And I'm going to talk to you about what that means in plain language. So it used to be that you couldn't diagnose somebody with a major depressive disorder if they were very, very sad and depressed because they had just lost a loved one. The idea, the rationale was that, of course, a person is going to be really depressed when they lose a loved one. We're not going to give them a diagnosis name. This is normal. This is human reaction after losing someone so close to them. Well, in the DSM-5, for the first time, we can now give somebody a diagnosis of major depressive disorder even if they've just lost a very close loved one. And there's a lot of kind of controversy or debate around that issue. Some people are concerned that we're almost pathologizing normal human experience. And this is something that really for the first time in the DSM is it being talked about so much. This concern that DSM is pathologizing normal experience. We're now saying that if a person is sad and hopeless 3 weeks after their loved one dies, that we can give them a mental health diagnosis. So this is something that I want you to be aware of, that there is some controversy and debate about diagnosis and the pathologizing of people's experiences. I want to talk to you a little bit about selective mutism. Now, this is not a new diagnosis at all, but what is new is the way that they are locating this diagnosis in the DSM. Selective mutism is now for the first time listed in anxiety disorders. And the reason why that's important is because it tells us that people who are writing the DSM believe that selective mutism is an anxiety disorder. As a clinician, I can tell you I absolutely agree with them. It's important for you to be aware of that because selective mutism is a common problem in childhood. And sometimes when we have kids who are unable to speak at school, we look at them as willful, or we look at them as disrespectful, or they're being stubborn. We now know that researchers believe that selective mutism is when a child does not speak because their anxiety makes them unable to speak. So that's a change in the DSM, just basically where they place it. It says something about what they know about this disorder and why it happens. Another anxiety disorder that it has some changes is separation anxiety disorder. It's also not a new diagnosis, but there are some new implications for how and when we can diagnose this. So separation anxiety disorder, something that we often see in children. They're unable to separate from caregivers. They're unable to go to school or go to places where they need to be without their caregivers. Researchers and clinicians who worked on DSM-5 saw that even adults can experience separation anxiety disorder. And so they have now expanded the criteria to say an adult can be diagnosed with separation anxiety disorder when they have extreme difficulty separating from a loved one, a partner, or even a child. Another change is the categorization of reactive attachment disorder. So this diagnosis, some of you may recognize it. It's a disorder that we often see in the adoption world when kids have had serious problematic treatment early in life. Reactive attachment disorder is when children have extreme difficulty in attachments because of their early maltreatment. This diagnosis has basically been broken up into two separate diagnoses. We've got some children who seem to be unable to attach with anyone, and it's because of their early maltreatment that they just do not engage in attachments. We still call that reactive attachment disorder, but the new diagnosis name that we have here is disinhibited social engagement disorder. And that's for kids who kind of react in a different way to early extreme maltreatment. Some of you may see kids who have experienced early childhood maltreatment and they seem to be willing to or able to engage with anyone. They'll literally go up to a stranger and sit on their lap. Or they might feel comfortable just leaving the building with a stranger and you worry about them because that might put them at risk. That's what we might call disinhibited social engagement disorder. So again, reactive attachment disorder is not a new diagnosis, but what's new in DSM-5 is that that diagnosis has now been broken down into these two different disorders, and they basically outline different patterns of reaction to extreme early childhood maltreatment and problems with attachment. And the last change that I want to talk to you about in DSM-5 is gender dysphoria. And so we used to have this diagnosis called gender identity disorder, and it almost implied that there was some kind of confusion on the part of the individual and their gender. And DSM-5 makes it very clear that gender dysphoria is not about confusion. Gender dysphoria is a diagnosis that we might use when people need clinical services because their expressed gender or the genitalia that they exhibit physically does not line up with how they identify themselves and their gender. So again, the change in language is very important because it points out this is not about confusion. This is about the person feeling uncomfortable with the gender that their body presents with. So I wanted to let you know that there are new diagnoses. Every time we have a new update to the DSM, we lose some diagnoses, we get some new diagnoses. Other diagnoses are kind of fine-tuned. Here are some new ones that I thought might be relevant and informative to you. So the first is disruptive mood dysregulation disorder. And this new diagnosis came about because of the idea that far too many children were being diagnosed with bipolar disorder. So I'm not sure how familiar you are with bipolar disorder, but it's considered a serious mental illness. It's one of the diagnoses that is considered to pretty much never go away. It is a lifelong disorder, and the treatments for bipolar disorder are very serious, including mood-stabilizing medications, which often come with pretty serious side effects. So the people who were contributing to the development of the DSM-5 were very, very concerned because many children were getting diagnosed with bipolar disorder, and it's a serious diagnosis. And they said, you know what, we've got to do something about this. It's possible that these children actually don't have bipolar disorder. Maybe there's something else going on. Maybe it's developmental. Maybe it's something they'll outgrow. Maybe we should come up with a different diagnosis to get them the services they need, but something that is not as heavy of a label, that doesn't lead to as serious interventions and treatments as bipolar. And so they hypothesize and postulate that maybe children who are having extreme acting out behaviors that might look like bipolar disorder, maybe it's something to do with their mood, and maybe it's something to do with they cannot regulate their mood yet. And so a disruptive mood dysregulation disorder is a brand new diagnosis. Some people were very concerned before the DSM-5 came out. This is a diagnosis, this was their concern. This is a diagnosis that children are going to get now when they have extreme tantrums. Are we now going to pathologize children's tantruming behavior? We all know that tantrums are developmentally appropriate, even for children who are into their preschool years. And so, of course, a lot of people were concerned that this was going to be an overused diagnosis. Really, we have not yet seen the implications or what the outcome of this new diagnosis is. But it may prevent some children from getting a bipolar disorder diagnosis too early. Another diagnosis that is somewhat been controversial is the premenstrual dysphoric disorder diagnosis. So this is the first time in the DSM that only women can get this specific disorder. And this is a mood disorder that has mood fluctuations related to the woman's menstrual cycle. So again, what's the controversy? Some people say mood fluctuation related to menstrual cycle is normal. Why would we pathologize it? Why would we give that a psychiatric diagnosis? Other people argue, well, if a woman experiences mood problems related to her menstrual cycle, and if we could provide services that can help her, why wouldn't we label it? So again, there are both sides. There are different sides, but again, this is a new diagnosis that I thought you might want to be familiar with. The next is hoarding disorder, and certainly if you've watched TV over the past 10 years, you know that hoarding as a problem is not a new issue. But I think that this is a good example of how the DSM evolves over time. Behavioral issues, emotional issues seem to be apparent. The committee takes things into consideration. What are they seeing in research? What are they seeing in clinical settings? Is it enough to indicate that we need to make a new diagnosis name? And with hoarding disorder, they decided that yes, it's enough of a problem in American society that we need to give it a diagnosis name. And so we have hoarding disorder. Another one that's very similar is binge eating disorder. And binge eating disorder is a little different from our typical eating disorders. The ones that we hear most about, anorexia and bulimia, really those folks are very over-concerned with their weight and size. And with binge eating disorder, that's not necessarily a problem. What's a problem in binge eating disorder is episodes of extreme, out-of-control eating. And again, DSM-5 looks at what's going on in American culture, what seems to be problematic. They make decisions on whether we should make a new diagnosis or not, and they decided that binge eating disorder is a new diagnosis that is needed in our culture. And finally, we've got skin picking disorder. And so I want to go back to that issue of does DSM pathologize normal human behavior. So many of us here might say, skin picking, lots of people pick their skin. Does it mean that they need a DSM diagnosis? Well, the first thing I want to tell you is that in order to be diagnosed as a clinical disorder, it needs to be problematic enough. It needs to interfere with the person's functioning. And just because somebody picks their skin doesn't mean that they need a psychiatric diagnosis. So that's something that is on the clinician to make decisions about. But anyway, apparently skin picking has become problematic enough in our society that they decided that a new diagnosis needed to be identified. So as we discuss new diagnosis, I also want to let you know that sometimes diagnoses are taken out of DSM as it is kind of, as it evolves over time. And I want to give you an example that is a pretty kind of interesting example, and I think it's a good example of how the DSM really evolves with our culture over time. So some of you may be surprised to hear this, but homosexuality was in the DSM until 1973. So only 44 years ago, if somebody was homosexual, they were considered to be mentally ill, according to the DSM. Now today, if you walked into any ethical and professional mental health professional's office, they would absolutely not identify you as mentally ill because you're homosexual. But that's kind of the way the DSM goes. In 1970, when homosexuality was still in the DSM, it was a reflection of what those psychiatrists believed at the time about what is normal, what is not normal, what is pathological, what is not pathological. And so I give you that example because I want you to know that sometimes maybe the DSM is wrong, or certainly we can't say that the DSM is always right, because if we look back in time at somebody in 1970, we certainly wouldn't look at them now and say, oh yes, they were mentally ill because they were homosexual, and now they're not mentally ill. But this lens is a lens that has been decided by some people, and they are influenced by their culture, and they are influenced by their societal norms. And so we have to keep that in mind, that that the DSM really does reflect kind of what's going on in our culture and societal values, and at the bottom line, the values and ideas of the people who are writing the DSM. So let's talk about what does the DSM provide, and what is DSM diagnosis, and what does it look like. So the DSM-5 provides us with chapters of disorders or diagnoses. And some examples of the disorders are anxiety disorders, depressive disorders, eating disorders, disruptive impulse control disorders, psychotic disorders. So they're chapters of disorders, and they're organized by commonalities in their risk factors and treatments. So all the disorders that seem to be related to anxiety are going to be in the same chapter. And all the disorders that seem to be related to eating problems are going to be in the same chapter. And their risk factors tend to have risk factors in common, and generally their treatments tend to be common within those chapters. So the DSM provides us with diagnosis names, and it also provides us with the corresponding ICD-10 codes. So you remember earlier I told you that the International Classification of Diseases is an international document. I want to bring that back for a minute. So all over the world, no matter where you go, if you're diagnosed with varicella in the United States, we call it chickenpox. But they don't call it chickenpox everywhere. They might not even call it varicella everywhere because they speak different languages. But no matter where you go, if you are diagnosed with that virus, you are going to get the same ICD-10 code. The ICD is truly international. Everywhere in the world, they're using the same system of number codes. Now, the DSM-5 tries to stay in line and tries to give diagnosis names to corresponding ICD-10 codes. But again, DSM-5 diagnosis names and diagnostic criteria, they are from American psychiatrists. So a lot of times, there's really good overlap between DSM-5 and ICD. 10, but it's not a perfect, there's not a perfect correspondence there. So the DSM-5 gives us diagnostic criteria. What do we mean by diagnostic criteria? Symptoms and behaviors. They also give us duration, meaning we can consider this to be a disorder if the person has had this symptom or that behavior for X amount of time. For any of the disorders in the DSM, the issues, the behaviors, the symptoms must be not developmentally appropriate and must impact functioning. So what does that mean? If a child cries when they're being separated from their parent, that's not necessarily a problem, right? We need to think about, is it developmentally appropriate for that child to be upset when separating from their parent? If the child is 3, of course it's developmentally appropriate. We're not going to diagnose that as a problem. The child is 17 and is crying so much because she can't be separated from her caregivers. That may or may not be developmentally appropriate. So these are things that we need to keep in mind. Also must impact functioning. So to go back to that example of skin picking disorder, many of us probably pick our skin once in a while. Does it impact our functioning? Does it make me not able to go to work? Or does it make me embarrassed in social situations? Those are things that might kind of prove that it impacts my functioning. So the DSM provides us with chapters of disorders and diagnoses. It gives us the diagnosis name and the corresponding ICD codes. And it gives us diagnostic criteria. And basically the diagnostic criteria are symptoms and behaviors, guidelines for time frames, and it reminds us that we're not going to diagnose something unless it's developmentally inappropriate and if it impacts the person's functioning. So just really quickly, I wanted you to see what a diagnosis might look like. You may or may not be a clinician who is going to diagnose others, but you may be looking at your own diagnosis. You might be looking at your child's paperwork. So I want you to understand kind of what you might see and what it means. So let's talk about this example. Selective mutism is the diagnosis name. That F94.0, that's the ICD-10 code. That's that international code. No matter where in the world you go, if you have issues and behaviors around not speaking in certain situations, F94.0 may be that code that they give you. When clinicians document a clinical, psychotherapy or mental health diagnosis, they may also document medical issues. And the reason why they do that is because our medical functioning can impact our mental health functioning. And lots of times, medical treatments for our medical issues can also interact with our mental health. For example, juvenile diabetes. There could be mood issues related to just being diabetic. But then also, if my diabetes is uncontrolled, that might even have a more profound impact on my mental health functioning. So clinicians who are focusing on mental health may also write down medical issues because it's important for them to be aware of. You'll see that I listed in this example homelessness, an academic or educational problem. So these are not diagnoses that we're saying, these are not pathologies of the individual. These are circumstances of the person's life. And it's important for mental health professionals to be aware of these circumstances in the person's life because they impact the person's functioning. So in the DSM, there are many different psychosocial and environmental factors. It could be parent-child problems, it could be housing problems, it could be economic problems, it could be homelessness, it could be history of abuse, all kinds of things. Mental health professionals might document these because they want to give a picture of the context of the client. Because when we look at this picture, you could see that it actually helps us to understand the client. Let's say that this is a little girl who is not speaking at school. When we look at the fact that she's homeless, and we look at the fact that she's got diabetes, and we keep in mind also that she has academic or educational problems related to her not being able to speak at school, it might help us to understand, okay, what child wouldn't be anxious if they're homeless? What child wouldn't have difficulty in school, maybe speaking at school, if they've got all kinds of medical issues going on? So the first thing that the clinician lists, the mental health clinician lists, is the clinical disorder name, and that's the DSM diagnosis. But then later, they might also document medical issues and psychosocial and environmental problems. And again, it's to give context, to give understanding of the client and their experience. So how does a mental health clinician come up with that clinical disorder, that DSM-5 diagnosis? Well, one of the first things that I want to let you know about is that there are no lab tests to identify these mental disorders. So if you're suspecting that your child has diabetes, you know what test you probably have an idea of what kinds of tests that your medical professional would do. You say, doctor, I think my child has diabetes. The doctor can order lab tests. They can order blood work. You can go to an endocrinologist who can look at their blood and see, is everything okay there? Your child falls out of a tree and their leg hurts really bad and they can't stand on it. You have a sense of what tests need to be done, right? And certainly when the medical professional gets to your child, they have an idea of what tests need to be done. They know that they need an x-ray to look and see if the bone is broken. Okay, so this is where mental health differs tremendously from medical health, physical health. In mental health, we do not have lab tests for these mental disorders. We do not have objective, black and white ways of testing to see if somebody has this diagnosis. All of it is human. And so what are the human things that go into determining DSM diagnosis? Well, first is what we might call intake or assessment or biopsychosocial assessment or clinical assessment. That usually includes clinical interviews, meaning mental health professional talking to people. It could include clinical assessment tools. Clinical assessment tools are questionnaires, paper and pencil tests, or maybe even computer tests that have specifically been designed and researched and documented to be able to measure symptoms. So that may be a part of the clinical interview. Most of the DSM diagnosis is going to be based on caregiver report and observation. So this is really, really important to keep in mind. These DSM-5 diagnoses, they're very important. They become major parts of students' plans at school and treatment plans in psychotherapy. Most of the process of coming up with that DSM diagnosis is mental health professional talking to caregiver and child and observing child. It's a very human process. It might also include record review, where the mental health professional looks at previous mental health records, including previous diagnosis, and gathering information from other sources. But again, I want you to remember that there are no objective tests. It's not as if I could just go in and go under a machine and know that I have an anxiety disorder or I have a bipolar disorder. It's based on conversation and gathering information in a verbal way. So some more notes, some more thoughts on what happens in this clinical interview, things that I want you to be aware of. Rapport is a term that we use for kind of developing relationship. Me as the mental health professional, that person that I'm interviewing, feeling comfortable with me, wanting to share information with me. It's never the case, even when a person is happy to come into therapy and wants help, it's never the case where the person walks in willing, able, and comfortable sharing all of their information, all of their stuff, all of their burdens, all of their worries, all of their traumas. It takes time to get to the point where I feel comfortable sharing information, all of the information, the truth of the information, the dark stuff, the stuff that is upsetting to talk about. So it's something that even if I'm a skilled mental health professional, it takes me a while to get to know that individual. The other thing that I want you to think about is that my mood, your child's mood can change over time. Now imagine this. Imagine you're in the most angry mood of your life. Can you think of the time that you were more angry than you've ever been in your life? Can you imagine if a mental health professional was evaluating you at that time? Would it make sense for them to diagnose you based on how you're presenting at that moment, your angriest moment of your life? Would the diagnosis that they come up with then really be a good reflection of you on a normal day? Probably not, right? Another idea, think about your most depressed moment, the time in your life where you felt the worst. If somebody were to evaluate you then and to come up with a clinical picture or a DSM diagnosis of you at that time, would that diagnosis be a good reflection of who you are all of the time or most of the time? Probably not. So I want you to keep that in mind, that DSM-5 diagnosis is really like a clinical picture of the client at that moment, and it may not be a great representation of them all the time. It may just be a small snapshot of how they are at that moment. So what else should you know about DSM-5 diagnosis? Usually, in most situations, the DSM-5 diagnosis is going to be determined by one clinician. And when I say clinician, it could be a pediatrician, it could be a psychiatrist, it could be a social worker, a psychologist, a nurse, any person who is a medical or mental health professional. The other thing I wanted to clarify for you, if I haven't already, is that psychiatrists are medical doctors with special training in mental disorders. So we've got medical professionals and we've got mental health professionals, and we can all come up with DSM-5 diagnoses. In general, when you bring your child or you go for yourself for an evaluation, it is one person who is coming up with that DSM diagnosis. Now there are other situations that vary. For example, if you bring your child to a clinic that is multidisciplinary, your child may be seen by a number of professionals, and they may all do their own interviews, and they may all use their own clinical assessment tools, and they may actually collaboratively come up with a DSM diagnosis. Or if somebody is hospitalized, they may be evaluated by a psychiatrist and a nurse and a social worker, and those professionals may get together to collaborate on a diagnosis. But most often, in outpatient settings, it's going to be one clinician coming up with that diagnosis. And the other thing is, it's usually in one session that that diagnosis is made. And people are often surprised by that. But the reason for that making a diagnosis in one session is that usually that session is going to be billed for, and the session cannot be billed for unless there is a diagnosis. So very often there's pressure to come up with a diagnosis right away. Believe it or not, sometimes that first assessment could be as short as 15 minutes. Sometimes it could be as long as a few hours. So it varies depending on your setting, and it varies depending on your mental health professional. But think about this. It is possible that you and your child might only meet with one mental health professional for 15 minutes before they determine your child's diagnosis. That's the reality of what often happens in clinical settings. What happens during this one session, hopefully it's longer than 15 minutes, it could be up to a couple of hours. And in some settings, it is actually over a number of weeks, which is a much more holistic view of the client. If we saw you on your worst day, but then we saw you 2 days later, and then we saw you 4 days later, we might get a better picture of what your mood is generally like, right? Would it be fair of anybody to be evaluated on their worst day and carry that diagnosis forever? No. So I want to make sure that you know that, so that we can prevent kids from getting labels that they really shouldn't carry forever. So in this one session, or after that one session, maybe more, hopefully, the clinician is going to look at the diagnostic criteria in the DSM-5. And so under each diagnosis, the DSM-5 gives us diagnostic criteria, basically descriptions of symptoms or behaviors. And I wanted to give you a couple of examples. So some diagnostic criteria are more objective. So this is a diagnostic criteria for trichotillomania. It's one of a few diagnostic criteria. Recurrent pulling out of one's hair resulting in hair loss. So that's pretty objective. Some are more subjective. And here's an example from attention deficit hyperactivity disorder. And I bolded the words that I thought made it even more subjective. Often fails to give close attention to details or makes careless mistakes. So again, I want to point out that there's a lot of interpretation that can go on here. Whether I'm meeting with a child, or Mr. Smith is meeting with a child, or Dr. Jones is meeting with a child, we might all interpret this differently. Often fails to give close attention to detail or makes careless mistakes. So again, there's a lot of human judgment and decision making that goes into figuring out if somebody meets the criteria for a DSM diagnosis. Finally, there's always discussion with the client and the family through this assessment process. I would argue that it's really good practice for the mental health professional to discuss the process of diagnosis with the client and the family. In fact, that's something that I do in my own clinical practice because I want to be really cautious and conservative about giving labels to kids or even adults. So every time I meet with a child or an adolescent or an adult or a family, I talk to them and I explain to them, I have to come up with a diagnosis for you. The diagnosis helps us because it will pay for your services. It also helps us because it helps me to figure out what might be the right treatments for you. I'm going to ask you some questions so that you can help me figure out what is the right diagnosis for you. Now, this is something that I do in my own clinical practice because I think that it helps me be an informed decision maker about diagnosis of clients. I'm not saying that all professionals or mental health professionals do this. Some do, some don't, but it may be part of the process. So how accurate is DSM-5 diagnosis? One of the questions that might be helpful to think about is how often do two different clinicians come up with the same diagnosis for a client? And if any of you have ever taken a research methods course, you might remember this term of inter-rater reliability. For those of you who haven't, I'm going to try and make it pretty simple. So inter-rater reliability is a statistical term, and it helps us to understand how a tool performs when many different people use the same tool. And so if a tool is used by two different people and we both come up with the same results, we would get a 1, or the tool would get a 1. 100% agreement. We both get the same results. So for example, Dr. Martinez and Dr. Smith are evaluating Joey. Dr. Martinez and Dr. Smith evaluate Joey with this specific tool. We both come up with the same diagnosis for Joey. The tool gets a 1. Sometimes Dr. Martinez and Dr. Smith are going to evaluate Joey and come up with different results for the same kid. That could be a 0. Most of the time when we're evaluating the inter-rater reliability of a tool, it's not a perfect 1 and it's not a perfect 0. It's somewhere in between. The long story short of inter-rater reliability is that the closer to the number 1, the better, the more reliable the tool is. Now, they did research for the first time. DSM-5 is the first time that the committee actually did research to study how reliable are the DSM diagnostic criteria. And what they did was they took their kind of rough draft of the DSM-5 and said, use these criteria and see, do you clinicians come up with the same diagnosis for the same person using our diagnostic criteria? What kind of results would you hope to see? Well, I would hope to see that lots of the diagnostic criteria came up with 1s. So it didn't matter which doctor evaluated the client. They're all coming up with the same diagnosis for the client. For example, if you go to the emergency room with that leg that hurts really bad and you can't stand on it, you expect that it doesn't matter which doctor is going to do the x-ray of you. It doesn't matter which doctor is going to examine you. They're both going to come up with the same answer, that either your bone is broken or it's not. You want them to be reliable. So I would like to see the DSM-5 criteria be reliable. Lots of ones in their statistical evaluation. So here's some of the results that they found. When looking at clients with autism, only 69% of the time did clinicians agree on the diagnosis of that client. Using DSM-5 criteria, only 69% of the time did they agree on the autism diagnosis for clients. Only about 61% of the time did they agree on ADHD diagnosis. Oppositional defiant disorder, which is another childhood disorder, behavioral disorder, lots of times we see it in school settings. Only 40% of the time did two different professionals come up with the same diagnosis for that child. The statistics get even lower. So what does this mean? This means that for child clients, two different clinicians came up with different diagnoses for the same client between 31 and 75% of the time. For adults, the rate of disagreement was between 22 and 80%. Now, this is research that was done by the American Psychiatric Association. So, in researching their own tool, they found that a lot of the time, using the diagnostic criteria that they developed, two different clinicians are not coming up with the same diagnosis for the same client. Is that a problem? It could be. Diagnosis using the DSM-5 is not without problems. As we talked about before, some people are concerned that the DSM-5 is really overreaching. It's starting to pathologize things that are normal, like depression after losing a loved one, like mood fluctuations related to menstrual cycle. As I just talked to you about, there are real concerns about inter-rater reliability, and that's a statistical term, but what does that mean for you? What it means is that even though everyone's using the same DSM-5, if you go to doctor number 1 or doctor number 2, you're likely to get two different diagnoses of your child or two different diagnoses of yourself. And what's the problem with misdiagnosis? Well, misdiagnosis and overdiagnosis may possibly lead to mismedication and overmedication. As we said before, psychotherapy, probably not that problematic if we're talking about maybe providing the wrong treatment, because we're working on social skills and problem solving, etc. But when we're talking about medicating, we need to really be concerned about the fact that people could be mismedicated or even over-medicated. Stigma, it's something that I'm bringing up for the first time, but it's something that you should I'm sure you're probably already aware of it. Sometimes a person having a label actually prevents them from opportunities. Sometimes a kid can't get into a program if they have a specific diagnosis, or sometimes a person can't get into a specific housing program or educational program or employment program if they have a specific diagnosis. So the idea that I have this label and society may treat me differently because of it is a very real one. And so because of stigma, we want to be cautious and we want to not get diagnoses, especially if they're not accurate. So what is a DSM diagnosis and what is it not? I've talked to you about what the diagnosis is. It's a language, it's a label, it's something that helps us get reimbursed for services, it's something that can lead us to treatment opportunities, it could lead us to better communication between professionals, but there are some things that a DSM-5 diagnosis is not. First of all, a DSM diagnosis is not always correct. as we just discussed, between 31 and 75% of the time, clinicians' diagnosis of the same child varied. DSM-5 diagnosis isn't truth. What do I mean by that? In 1970, a person was considered mentally ill if they were homosexual. We would not say that today. So remember that DSM-5 is a lens that we look through that is a reflection of some people's ideas, and it's not necessarily true. Something that I want to bring up that's kind of new is I want you to recognize that a DSM-5 diagnosis is not a life sentence. And what I mean by that is that, first of all, I could meet the criteria for a diagnosis today. It doesn't mean that I'm always going to meet the criteria for that diagnosis. My life situation may change. My symptoms and behaviors may change. My presentation may change over time, and people might actually figure out, I never met the criteria for that diagnosis to begin with. The other thing is that people can change, especially children can and do change. And so even if I do meet the criteria for a diagnosis now, it doesn't mean that I will carry it forever. For example, many children I treat who have a diagnosis of selective mutism, 6 months to a year later, they no longer carry that diagnosis because they have found ways to cope with their anxiety. They feel more comfortable in their situations. The professionals in their environment have helped them to feel more comfortable in their relationships, and so they no longer have these issues. So lots of times treatment, psychotherapy, changes in the environment can make the diagnosis go away, and that's a really good thing. A DSM-5 diagnosis is not necessarily a solution. It is a snapshot. It is a view of how the client is presenting now. It can be a pathway to solutions. But having a diagnosis does not necessarily give you the answer. We are all dynamic individuals. Even if I have the same diagnosis as the person next to me, it doesn't mean that the treatment that I need is going to be the same as the treatment for the person next to me. We're complex. What's going to be effective for me may not be effective for the next person. So the diagnosis may be a pathway to solutions, but it is not a solution in itself. The last thing I want to remind you of is that DSM-5 diagnosis is not universal. Remember, this book was developed by American psychiatrists because they wanted to frame and they wanted to define mental health in the United States. The lens that we use here is not the lens that is used universally, and it's important to keep that in mind. So I've given you a lot of information. Some of it may make you a little bit more cautious. It might make you a little bit more skeptical. What can you do to get an accurate diagnosis? There are things that you can, and I encourage you to do. I encourage you first to really try to seek out professionals who are trusted and respected. Use your connections, your social connections, your friends, your colleagues, to find your way to professionals who have good reputations for being skilled at what they do. Trust your gut feelings. Lots of times we have to go to providers because they're in our network. They accept our insurance. They have hours that are convenient to us, or they work with our lives. It doesn't necessarily mean that it's the right person for you or the right person for your child. And if you're feeling that, that it may not be the right fit, then I would encourage you to trust your feelings. Ask and expect to participate in the process of diagnosis, and seek additional diagnostic assessment if you need to. You might consider it a second opinion, or asking for another view of your child or yourself. I think that's always a good thing to keep in mind. I apologize, I know I'm short on time. I wanted to share with you a couple of resources, folks, but I just wanted to wrap up with this last thought. At best, DSM diagnosis is a process. It's a part of a comprehensive assessment where the clinician and the child and the family are developing a trusting working relationship. Agreeing upon a diagnosis can be a helpful beginning step on the course of effective treatment. I have a couple of resources for you here that I hope can be helpful to you. Feel free to check those out when we have more time. I apologize I went long. Do you have any questions for me if you feel like staying around? And thanks for your time, folks.
Colleen, can you go back to your resource slide just so we can
Yes.
keep it up for a little bit? Thank you.
Sorry about that.
Okay, I'm going to launch right away with questions. I have a couple of specific questions, okay? And this one is, do they no longer give access 1 through 5
Good
anymore?
question. Yes, so DSM Diagnosis used to be on 5 axes. For a long time we had axis 1, 2, 3, 4, and 5. And that was a way of organizing diagnosis, and we don't use that format anymore. So axis 1 and 2 are now together in our clinical disorders. So it used to be clinical disorders and personality disorders and mental retardation. Now we list our clinical disorders, our personality disorders, and our intellectual disabilities all together. We list medical issues if there are any. We list psychosocial issues if there are any. And we no longer use a global assessment of functioning. It's just a different way of organizing diagnosis now, and you're right, axis 1 through 5 is no longer part of the way that we diagnose, but we still put the same information in there, but in a different way.
Got it. Okay. So another kind of same idea technical question.
Yep.
Why are mental health practices and hospitals still using DSM-4-TR?
Yes, so they probably should not be doing that, especially because just in, I would say the past year, officially everyone in terms of billing, Medicare, Medicaid, insurance companies made the switch to ICD-10, and DSM-5 is aligned with ICD-10, and so people really should be using DSM-5 now because it is ICD-10 aligned. It could just be that the transition has been challenging for them, but most medical and mental health organizations, especially big ones that deal with Medicare and Medicaid, have made the transition to DSM-5 and ICD-10.
Got it. Okay. Now, in your list of clinicians that would be using DSM-5, the question being raised here is, would you include a school psychologist in that group of mental health professionals, given that they have a lot of access to multiple exposure and so forth, and a good observation of what's going on with the kid?
Yeah, so school psychologists really do have great opportunities to have a lot of interactions with kids and to observe them, but I don't believe that they use DSM diagnosis. I believe, and I could be wrong on this, but I believe that as members of the child study team, they're only coming up with educational classifications. I don't believe that they come up with DSM diagnosis, but I actually could be wrong on that.
Okay, but in terms of their observations, they would be pretty unique in a school setting, you know.
Yeah, I think that,
in that respect.
Yeah, I think that any professionals who have opportunities to see kids at school do get a chance to get a more global view of how kids are doing. The other thing that I would say to keep in mind about school is that the expectations of schools aren't necessarily developmentally appropriate. And so sometimes we have kids who are 3 years old who are being referred for an ADHD assessment because they can't sit down and focus. And quite realistically, 3-year-olds aren't meant to sit down and focus for very long. And so sometimes the developmental expectations of schools are not really developmentally appropriate. And so we also have to keep that in mind. Just because a child can't sit still doesn't mean there's something wrong with him. It might mean that the setting is not developmentally appropriate.
Okay. Is Asperger's still under the autism umbrella?
Yes, absolutely, and that's the one that I forgot to mention. It used to be its own diagnosis name, but now it is subsumed under autism spectrum disorder. There's also another new diagnosis in that chapter, and it's about social communication. But really, most kids who met the criteria for Asperger's disorder, they're going to fit under that autism spectrum diagnosis.
Okay, excellent. All right, so this is a question that's a little bit different, so from what we've covered so far. So this is an in your opinion question, okay? Yep. Should students with Lyme disease and anxiety because of the Lyme disease be able to attend school? Apparently, there are physicians in wherever this individual lives that put kids on home instruction, and I'm assuming this is faculty here, we are having difficulty getting them back to school. So what are your suggestions for the school personnel in this situation?
Yeah, so I totally understand that challenge. So there's two things going on, though. There's the medical diagnosis of Lyme's disease, and then there's the mental health issue of anxiety. And so I can't speak to Lyme at all in terms of students functioning and what they should physically be expected to do, but I will absolutely tell you from a lot of experience that anxiety related to school attendance and school, what we call school avoidance or school refusal, are huge problems. And what I know from the research and from my experience is that the longer that kids are anxious about school and are allowed to avoid school, the worse their anxiety gets. And so I feel that that school personnel's concern about the fact that they don't want the child to be allowed to stay out of school for too long because the anxiety will grow. I absolutely agree with you. I can't speak to the issue of the physical impact of Lyme, though. So I would encourage those folks to talk with local medical providers and ask them about the physical functioning of students, and maybe inform the medical professionals about the psychosocial factors, the fact that avoidance and refusal and staying out of school often makes anxiety grow, so that they can make plans to transition kids back as quick as possible, as long as it's appropriate to their medical issues.
Okay, I do know, I've known people that have had Lyme disease, and they do talk about fatigue and being tired, so I guess that, you know, I could understand that myself, but you're right, it is hard to go back once you're out.
Very. I think that this is where teams should really try to be creative. Even if the student is experiencing extreme fatigue, there are ways that we could get them back to school, even if it's for half an hour a day. The length of time that a kid is out of school is always going to make it harder to go back. I'm sure some of us are experiencing that now because we've had so many snow days. Going back tomorrow is going to be harder. But for kids who are anxious, it's even harder. So I would say to think about how can we get them back to where they can handle it physically, but decreasing the amount of time that they're out. But again, maybe even going back for half a day or even for a half an hour just to keep that connection.
Okay, we've gone well over. I've got one more question for you, and then I think we'll wrap it up. Okay. At the end of your towards the end of your presentation, you talked about getting a second opinion.
Yeah.
So if you were to go for a second opinion, whether it's for, you know, yourself as the adult or the kid or whatever, what should you tell the second doctor about why you're there? Do you just not say anything about getting this other diagnosis, or do you tell them right up front you're here for a second? Like, how does that work?
Yeah. So first of all, I apologize that I went over. I didn't mean to keep you so long, and I appreciate those of you who are hanging in. Second of all, I think that that really brings up the issue of do I disclose prior diagnoses with current mental health professionals? And I think that that's where you kind of you really want to trust your gut. Do you trust this person that you're with? Do you feel comfortable with them? How much do you want to share with them now? How long before you share with them more. And you're always kind of trusting your judgment. I will say as a clinician, it's often helpful for me for people to tell me what other diagnoses have been made. But I don't automatically assume that they're correct, and I don't automatically write them down. But I do use that as information to kind of help me figure out, aha, is this diagnosis accurate or not? So sharing that information that somebody else has diagnosed me with X, Y, and Z, what do you think? I think that that can be quite helpful. Other mental health professionals, even maybe if their diagnosis was off, their view and their insight may be helpful to the current clinician. However, if you've gotten a diagnosis that you're just completely dissatisfied with and you do not think applies, and you're concerned what the new clinician is going to think, that is totally your right to not share that information. And that's something that you, as a client and a person who is pursuing services, you can always make that decision yourself.
Okay. And you know what? I'm going to ask you one more question, okay?
Yep,
and
sure.
then we'll end up. So, is it appropriate for a school to ask what the DSM diagnosis is for a student and make it part of their school record?
So is it appropriate for a school to ask what the DSM diagnosis is and then to have it as part of their record? I think that's why a lot of families wind up pursuing evaluation that is not connected to the school, because they want to protect their child from getting these labels, and I absolutely understand and respect that. I think that there's very real reason to be concerned that a diagnosis is going to be a label, and unfortunately that's often the case. So I think that it's always up to the parents when they are seeking services for their child. It's always their right to either allow information to be shared or not, and medical and mental health professionals are supposed to respect that, and legally they're required to. They cannot share information without parents' written consent. I think it's important for parents to know that they have the right to say, I want this information shared, but I don't want that information shared. Mm-hmm. However, lots of times it'll actually be helpful to the child if that information is shared. But I think that that is a decision that parents should think long and hard about, and even talk to their mental health professionals about it. What would be the benefit of sharing this information with school, and what are the possible risks of sharing this information with school?
Okay. Well, I think we're going to wrap it up here. Thank you. I'm going to turn this over to Kelly to just finish up, but that was a really great presentation. Thank you so much.
I appreciate it, and I appreciate all of your time, folks.
Thank you all for joining our webinar on demystifying the DSM-5. There is an exit survey which we need everyone attending to fill out. The webinar blog is open now and is available for the next 7 days on the NJCTS website for any additional questions that were not covered in tonight's presentation. That website is www.njcts.org. Also, an archived recording of tonight's webinar will be posted to the site. Our next presentation, Tourette Syndrome Medications, Past, Present, and Future, will be presented by Dr. Roger Kurlan and is scheduled for April 12, 2017. This ends tonight's webinar. Thank you, Dr. Martinez, for your presentation, and thank you, everyone, for attending. Good night.